Diabetic ketoacidosis is an important pediatric emergency that requires immediate action and appropriate management to ensure successful outcome. The last decade has seen tremendous changes in terms of understanding of pathophysiology of diabetic ketoacidosis and its complications, and have resulted in significant alteration with regards to management protocols for insulin therapy, fluid replacement, and requirement of alkali. The presentation will go through the basic aspects of diabetic ketoacidosis with special emphasis towards prevention of significant complications of DKA in different settings. So we'll touch base upon diabetic ketoacidosis as to when, what, and how of DKA. The first question which comes to our mind is, when should we suspect diabetic ketoacidosis? And DKA is one condition which should never be missed. Unfortunately, even in this day and age, a significant number of children present to us with diabetic ketoacidosis while their symptoms for type 1 diabetes have been there for quite some time. So it's absolutely essential to consider every child who is coming to us with diabetes, fresh diagnosis, to be a potential diabetic ketoacidosis unless proven otherwise, and to get a blood ketone done in that child immediately before sending the child home on insulin therapy. Diabetic ketoacidosis may also present as a vague symptom being managed for other conditions, in particular with regards to dehydration, and children who are dehydrated should usually be oliguric. So if your child is dehydrated and is having polyuria, one should consider the possibility of diabetic ketoacidosis or acute tubular necrosis or diabetes insipidus. Children who have tachypnea without evident chest signs should definitely consider the possibility of acidotic breathing in the setting of diabetic ketoacidosis. Those who have unexplained encephalopathy should definitely have got their blood sugar and electrolytes measured to look for any hypoglycemia, diabetic ketoacidosis, or dyselectrolytemia as a possibility, as well as those who present to us with acute abdomen. And we need to remember that DKA may be associated with increased counts and increased levels of amylase and lipase, which may erroneously lead to the diagnosis of pancreatitis in this setting. DKA, as we all know, is a make or break diagnosis, and if we delay the diagnosis, it may have a lethal implication as far as the child is concerned. So when do we consider it to be a diabetic ketoacidosis? And the word itself tells us all that we need to be diabetic, ketotic, and acidotic. So a child should have a hyperglycemia, a blood sugar levels more than 200 mg per dl, along with the presence of ketonemia or ketosis. And I think it's very important to emphasize out here is that urine ketones are not a very reliable marker of the level of ketoacids in the body. Urinary ketone strips typically measure acetoacetate, while the predominant form of ketones in a child with DKA is beta hydroxybutyrate. So therefore, urine ketone strips may not be a very reliable indicator, and that's why the role of blood ketone monitoring, which is now easily available, becomes important. And in a child with suspected DKA, we should measure blood ketones, which if less than 0.6 are considered to be normal, and values beyond 1.5 are highly suggestive of impending diabetic ketoacidosis. And this, along with that, should obviously have acidosis. So all three of these conditions should be present to make the diagnosis of DKA quite evident. So let's look at a couple of cases. This was a 12-year-old girl with bronchial asthma, presented with acute severe asthma and shock, was managed with steroids, terbutaline, and fluid. And at that point of time, somebody did a blood sugar. It was found to be 320, and the child had acidosis. So we have a child who is presenting, as we discussed, with a respiratory symptom, and we have already seen that many children with DKA may present just with respiratory distress, although with negative chest signs, who also has hyperglycemia and acidosis. Now, does this child have DKA? This will be the key question that we have to look into. As we have discussed, we need to really prove that the child has all three components of diabetic ketoacidosis. So we have to look at ketones. And when we looked at the ketones, they were negative. So the diagnosis of DKA goes out. And this is the child who has typical stress hyperglycemia, has received beta agonists, has received steroids. And that's why she has a transient hyperglycemia, which is not an unusual situation. However, one must remember that children with transient hyperglycemia may represent those who have diminished beta cell function and have a propensity of developing type 1 diabetes later on in life. Another quite confusing situation, a 13-month-old boy with failure to thrive, whose weight was 6 kgs, was looking clinically very dehydrated, had metabolic acidosis, and blood sugars were quite variable from a range of around 90 to 334. So we actually see the child actually has dehydration, has acidosis, has mild hyperglycemia, and ketones are also present. Now, is this diabetic ketoacidosis? This may be DKA, but what we need to remember is that most children who come to us with this level of acidosis, this level of ketosis, would have much higher blood sugars than 90 to 334, and despite not even using insulin, the sugars have been fluctuating. So one needs to consider the possibility of alternative diagnosis, and clearly one of them is organic acidemia. Euglycemic DKA may happen in children who are actually having recurrent vomitings, and that's why they are not able to have high sugar levels, or it is often associated with pregnancy. But traditionally, if you have a run-of-the-mill of case of DKA, you will have very high sugars, ketosis and acidosis, where there will be no confusion. So once we know that the child actually has DKA, the next question is, what do we expect in that child? And in this regard, what we need to remember is that in most situations, diabetic ketoacidosis, we have a precipitating factor like infection, stress, or trauma, which tilts the balance of insulin deficiency on one hand and counter-regulatory excess in the form of growth hormone, cortisol, epinephrine, and glucagon on the other. And this process has varied effects. So insulin deficiency is associated with increased lipolysis, producing more free fatty acids, increased conversion of free fatty acid to ketone bodies, and this results in ketosis, which is a typical fruity odor of these children, in acidosis resulting in abdominal pain or cusped breathing. Counter-regulatory excess results in more process of glycogenolysis, producing more glucose, and this glucose causes hyperglycemia and osmotic diuresis, wherein we lose more of fluid, sodium, potassium, and phosphorus. So the effects of diabetic ketoacidosis are a combination of both insulin deficiency and counter-regulatory excess, and they result in the classical clinical picture of diabetic ketoacidosis. So what do you expect in a child who presents to us with DKA is a reasonable level of dehydration of around 5 to 10%, but what we need to remember is that in certain situations, the level of dehydration is often overestimated in DKA, and that may lead to unnecessary fluid boluses, predisposing the child to fluid overload and subsequently cerebral edema. So as a rule of thumb, one should consider a level of dehydration which is one level less than what we are really assessing in terms of clinical assessment for a child with DKA. Since assessment of dehydration may be difficult, many people consider a rule of thumb as far as pH is concerned, in the sense that if the pH is more than 7.1, one should consider approximately 5% dehydration. If the pH is less than 7.1 or we have a severe DKA, we consider it to be 10% dehydration. There is significant sodium deficit which happens with diabetic ketoacidosis, but we also need to consider that there is a possibility of pseudo-hyponatremia, in which the serum sodium levels will be inappropriately low because of high blood sugars, and therefore one may be more alarmed by hyponatremia than what the actual sodium levels are in diabetic ketoacidosis. Similarly, there is a huge amount of potassium deficit in diabetic ketoacidosis, but because these children have insulin deficiency and have acidosis, all the intracellular potassium is shifted out of the cell, and therefore the measured extracellular potassium is actually normal or high. But as soon as we start therapy, soon we start insulin and correct acidosis, all this potassium is going to go into the cell, and unless and until we correct it, we are going to develop severe hypokalemia. If we have a situation in which the potassium levels are low at diagnosis, it is a very, very significant condition, and we need to be very cautious in terms of starting insulin, because this child is going to develop severe hypokalemia very soon. Phosphate deficit is there, but the role of phosphate deficit and whether it plays an important role in the pathogenesis and oxygen dissociation curve is something which is debated in this regards. So how do we proceed with a child who comes to us with diabetic ketoacidosis? And obviously we have to assess the child in terms of airway, breathing and circulation, stabilize the child, look at hydration, put one level lower hydration than what you're expecting, look at level of consciousness and sensorium. Then we get blood gas to look at the severity of acidosis, serum sodium. Anion gap is a good marker of acidosis and ketosis, and electrolytes. Ketone levels are extremely important because they give us an idea about how severe the acidosis is, and if the blood gas is not easily available or not easily affordable, blood ketones provide a very good information about the trend of correction of hyperglycemia in this regards. We also need to consider correction of sodium levels, and for every 100 milligram per dl rise of blood glucose beyond 100, we should add 1.6 of to the serum sodium to get a corrected sodium picture. So how we start in terms of management? The management of DK in this regard should be considered in phases, and the first phase is usually just the hydration phase, in which we give some fluid, and just by giving fluid we expect the blood sugars to fall by around 200 points, because one, we are diluting already concentrated fluid, so that becomes more dilute, and therefore the blood sugar levels go down. And more importantly, the counter regulatory hormone levels will be suppressed once the hypovolemia is corrected, and that results in decrease of blood sugar in the initial phase. It's important to understand that we should not start insulin right away. We should start it after 1 to 2 hours after hydration, because if we add insulin in the initial phase, that will result in very rapid fall of blood glucose, causing severe changes in the osmotic equilibrium, resulting in predisposition to edema. Once the hydration has been achieved in the initial phase, it has to be continued over the next 48 to 72 hours, depending upon the severity of dehydration, with slower correction for most severe cases. And insulin should be started at that stage. And we need to remember that in most cases, insulin bolus is now not recommended, and we should just start insulin infusion. And with insulin infusion, one would expect a fall of blood glucose of approximately 50 to 100 milligram per dl per hour. So by around 5 to 6 hours, reasonably in most cases, the blood sugar should have fallen below 270. And at that point, acidosis usually doesn't resolve. So what we should do in this setting is to continue insulin till the time acidosis is resolved, and add dextrose so that we buy time in terms of continuation of insulin. So let's start off with the individual components of management. The first and most important component is the fluid management, and in most cases normal saline 10 ml per kg in the first hour has been recommended as far as treatment is concerned. There are now clear-cut guidelines that the child has no hemodynamic instability. If the pH is more than 7.1, there is no tachycardia, we may actually omit the fluid bolus in those situations. Subsequent fluid management should be an even correction of both deficit and maintenance for a period of around 48 to 72 hours. And the key, which has been happening over the last few years, has been to reduce the rate and rapidity of fluid correction. And what's extremely important to remember is that in any case, we should not be giving more than 40 ml per kg over the first 4 hours, and never double maintenance fluid should be given. So how do we go in terms of management? Next is about insulin, and in this regards, insulin infusion should be started in younger children and infants at around 0.05 unit per kg per hour, and in older children at 0.1 unit per kg per hour. IM insulin may be considered in resource poor settings and may be given at a dose of around 0.3 unit per kg on an hourly basis. We should always flush tubings of with insulin, because insulin can stuck to the tubings, and in the initial phase insulin may not really go to the child. It may just be circulating within the tubings, and the titration should be gradual in regards to insulin modification, should not be more than 10 to 15%. Potassium management is absolutely pivotal, and all children who have diabetic ketoacidosis after the hydration phase should be given potassium unless they are anuric, they have ECG changes of hyperkalemia, or the potassium levels are more than 6. Potassium should be given as 40 millimoles per liter in these situations, and one needs to be very cautious in children who have a potassium level less than 3.3 at diagnosis, because they are sitting on a veritable time bomb, and if we give insulin they will have a sudden hypokalemia and cause cardiac arrest in that regard. While on management, if the potassium levels fall, one must give priority to prevention of hypokalemia rather than correction of acidosis. A child is not going to die because of a blood gas showing a pH of 7.2 or a base excess of -12, but will die if the potassium levels go below 2 or 1. So if a child has become hypokalemic, has mild acidosis, don't worry in reducing insulin dose so that we can actually increase the potassium levels in that regard. Otherwise, this could be a major emergency. What about dextrose? So once the blood sugars resolve, we should add dextrose at around 5% when the blood sugars are less than 300, and then we can reduce insulin a bit later. Alkali therapy has no role in diabetic ketoacidosis. It causes CNS acidosis, hypokalemia, cellular edema, and should be reserved for children who have life-threatening hyperkalemia. When to decide about transitioning a child from IV insulin to subcutaneous insulin is decided largely based upon the child becoming well, conscious and eating, resolution of acidosis, and there should be an overlap of around 30 minutes to 1 hour if you are using regular insulin, and around 20 to 30 minutes if you are using rapid acting analog in this regards. So we'll now just go through this child, 14-year-old boy with severe diabetic ketoacidosis. Blood sugar is 720, base excess is -24, so it's a severe decay. Potassium is 5, weight is 30. So how do we plan in that regards? So we'll start off with ABC. Because the child looks into severe dehydration and decay, we'll start with 10 ml per kg of normal saline over 1 hour. Subsequently, we'll calculate maintenance for 2 days. In children who have a weight up to around 40 kilograms, typically if we use weight-based maintenance, it's adequate. But beyond that weight, body surface area would give us a better information about food requirement as far as maintenance is concerned. So for a 40 kg child, we have a maintenance requirement of 1.7 liters, which becomes 3.4 liters over a 48-hour period. Deficit of 10% becomes 3 liters. So this child requires 6.4 liter fluid over 48 hours, and we'll start off with normal saline and add 40 millimoles per liter of potassium. Now this does not mean that we have to continue fluid for 48 hours. Once the child becomes stable, is conscious, is eating and acidosis is resolved, we can then stop fluids and correct with oral hydration subsequently. So on follow-up, we found that 4 hours of treatment, nothing has changed. The child still has severe acidosis and the blood sugars are high. So what went wrong? So if there is no response to the initial phase, one needs to think about whether we actually calculated insulin appropriately. This may be a mistake often. Whether we have diluted it too much, particularly if you are using a burette set, this problem may happen. Whether the insulin is bound to tubings, and this is very important. And in this regard, we should flush around 20 ml through the saline throughout the sign. And whether the child actually is in shock, because in that situation, counter-regulatory excess will result in poor control of hyperglycemia. At 8 hours of treatment, blood sugar becomes 190. The sugar has come down and base excess is still -12. So what do we do? So we have persisting acidosis with resolution of hyperglycemia. We need to continue insulin and add dextrose. Depending upon blood sugar, 5 to 10% dextrose should be added. Now, we have added insulin and dextrose, and what we expect is that we are giving insulin dextrose drip, and that will cause hypokalemia. So at 10 hours of treatment, blood sugar is 220, base excess is -11, and potassium is 2.6. So child now is developing hypokalemia. So what do? I think what should be very clear is that the priority here is to prevent further deterioration of hypokalemia and not correction of this acidosis of base excess of -11. So here hypokalemia will clearly get a precedence over metabolic acidosis, and in this setting we should reduce the insulin dose, increase potassium in the infusion, or maybe even withhold insulin if the child is not improving. At 14 years of treatment, the child suddenly becomes comatose, sugar is normal. What is the cause? This is one thing that every pediatrician who is treating with a child with DKA should be cautious about: development of cerebral edema. Cerebral edema is common in children who have severe DKA, results with rapid fluctuation in blood sugars, osmotic shift, typically occurs around 6 to 12 hours of therapy, but may actually be present at diagnosis or may develop at any time. So if your child who is sick, who has unequal pupil, who has hypertension, who has bradycardia, and is having a central Cheyne-Stokes self-respiration, think cerebral edema, and immediately mannitol or 3% saline should be given. Please never wait for neuroimaging because that can often be lethal. Cerebral edema has been reported in around 1 to 2% cases in Western literature, but it's much more common in Indian settings, close to around 20 to 30%, has a 30 to 40% mortality. A severe case usually occurs in 6 to 12 hours but can occur at any time. It's a clinical diagnosis, and mannitol should always be there bedside in a child who is being managed with diabetic ketoacidosis. At 20 hours of treatment, child is better, blood sugar is 190, base excess is normal. Conscious, what do? Now is the right time to shift the child to a subcutaneous regime of insulin. Should be allowed orally. Started with regular insulin, and we can actually use a long-acting and a short-acting insulin also if we want to use it. Insulin infusion was stopped in this case, and what happened was that 2 hours later blood sugar again became 560, and this was clearly because there was no overlap which was given between giving the subcutaneous insulin and starting insulin infusion. So there should be an overlap of at least 30 to 60 minutes in children who have been given regular insulin, and around 20 to 30 minutes in children who have been given rapid acting analog once the DKA has resolved. So just to summarize the management of diabetic ketoacidosis, the initial phase is typically a fluid bolus of approximately 10 ml per kg. Subsequently, we start with deficit and maintenance over 48 hours, followed by insulin infusion at around 0.1 unit per kg per hour. Potassium should be given to all children unless there is anuria or hyperkalemia. Once the blood sugar becomes low, dextrose should be added. We should always take care of not giving bicarbonate at any point of time, and beware of cerebral edema. Just to summarize, in a child with diabetic ketoacidosis, we don't need to give any further insulin bolus, too much fluid, or soda bicarbonate, but think potassium and all, timely dextrose, and think cerebral edema.